Today, I am going to talk about peritoneal endometriosis, and I dare to talk about peritoneal endometriosis. I dare, and I will be as transparent and as detailed. Please forgive me if you have questions, you'll ask. The peritoneal endometriosis is an interesting topic for me because I practice in New York City, and I see half of my practice is, in a way, that because truly peritoneal endometriosis is the enigmatic part of endometriosis that is undervalued in general by scientific writers and talking heads and experts. So what gives endometriosis enigma and bad reputation is this part. There's no blood test. There's no imaging. It's the patient that brings herself willing to be diagnosed. She wants to be vindicated. She wants to be validated. And in places like New York, I cannot tell a patient, I can't look inside you, and I will. And this brings me to present some data. I'm not going to talk about these things. Bilateral hydronephrosis, multiple pins at the sacroiliac joint, and others on sciatic, multiple pins again. I've seen these patients, and I operate these patients. If you look at this. What is that on the right-hand corner? Anybody can tell what this is? Right-hand corner, do you see this? Mesh? How about, no, it's not a mesh. It's not mesh, but it's not a cardiac stent. It's a stent in the rectum. Unbelievable, isn't it? We're going to talk about these a little bit. So I'm going to focus on peritoneal endometriosis, not these. So yesterday, I want to finish my IVC injury yesterday. You saw this, right? So this is where we left. Everybody asked me, are you going to share what you guys really did? This is a catastrophic, very mortal situation. By the time you go in, IVC here, it's going to take some time. You have to do open laparotomy, and you can lose the patient. The good part is, there's only good part here with the robotic arm immediately put the pressure, and he stayed there. Literally stayed there until we decide what to do, and she didn't bleed after this point. Luckily, the cardiothoracic surgeons came, vascular, everybody is in the room, bloods are being asked this. We waited like 10 minutes, 15 minutes, 20 minutes, and this hepatic surgeon said, I have a solution. And solution was this. This is a fibrous, and we are applying still, the leak is blocked. This is the patient who came from Johns Hopkins. I can tell you that. She came with pneumothorax. She had a surgery that, you see the incision up there. What happened was IVC was, inferior vena cava was tented up, and the surgeon got trapped with that. And he didn't realize it wouldn't be that close. So this is fibrin sealant patch, Everest. It's like a cement. I carry this in my room all the time now. It's in my room. So I think it's nice to know, because nobody knew about it. Only hepatic surgeons knew this. This is new. So it's the off-label use, never described IVC injuries, but they did describe in heart surgery for penetration wounds and stuff. So I am mesmerized with moon, obviously, as a dealing with a disease associated with menstruation. Full moon is important in the evolution of female brain and cycles. So in other words, what we see is really This is again, this is again full moon almost, but this is the eclipse that I went to Lake Champlain, and we see one part of we see one part of the moon. We never see the other side of the moon. To be honest with you, I never liked the Dark Side of the Moon. I really didn't like the song. It's not. I'm a Beatles fan, so I don't care about it. But there's a reason I didn't like most likely. I think poetically, Dark Side of the Moon represents endometriosis. So we can move from that. So 2 cartoons from New York Times, very favorite cartoonist, Luka Lubova. She did these things just for us, for the foundation. You see a woman trapped within her uterus. That's the dark side of the moon. And it's fertility situation, how the time passes and some woman never gets pregnant and suffers while the others enjoy their babies. Peritoneal endometriosis initially was introduced by whom? Sampson. The man is there. And he quoted peritoneal endometriosis in this writing 63 times. He was so obsessed with peritoneal endometriosis. He saw the disease really started from that. In his 1940, 15 years later, he said this, or 18 years have elapsed since the essential feature of this theory was published. Ever since that time, I have continued to be greatly interested in endometriosis of all types. He knows all types, especially the peritoneal type. Not only because it occurs more frequently than all others, it's clinically the most important, but also its pathogenesis is so tantalizingly alluring and elusive. It couldn't be put into better words like this. And it took 100 years, really, Donner group really identified 3 types of endometriosis. Why did it take somebody to write about after 100 years? Because the truth is, endometriosis is a difficult disease. In my practical experience, rectovaginal cul-de-sac closure due to endometriosis in the absence of endometrioma is very rare. I have rarely seen, in the absence of peritoneal pathology, just isolated. I have seen them, maybe, but I cannot count more than 10 in my life, all right? In the absence of peritoneal endometrioma, in the absence of peritoneal lesions, are less than rare, but infrequently seen. It's very difficult to see also endometrioma without peritoneal, but we do see them more often. All right, let's accept this. So what happens is, obviously, the closure of cul-de-sac, the endometrioma is a very dangerous thing and we have to be very careful because it could be silent. The patient may be admitted to emergency room, and in New York they treat them with antibiotics. So this is my experience. I want to share this as transparent as I can. I have these are just pure peritoneal patients. Excluded are the hysterectomies, deep endometriosis, endometrioma, chest cases, and everything. So this is last 10 years almost 1,000 cases. I excised, everything went to pathology, Lennoxville Department of Pathology. There is almost more than 13,000 specimens are taken out. And with all my honesty, 1/3 of the specimens, less than 1/3, are normal histology. I could explain that to you later, the way I could explain. But most importantly, half of them, for the last 10 years, I'm trying to do this, and I had multiple people worked on my numbers. It's hard to get, more or less always though, the positivity of my retrieval positive gland and stroma around 50 to 60%. When I started doing this blue dye technique, I started to remove more specimens, but more fibrosis and normal tissue also came up. And you know what? I went after very small lesions, and pathologists did not bother to exhaust the specimen. That's very important. So when there's already diagnosis was made, pathologist just said, normal, as long as there is endo moved on. And some cases I fought with them, some cases I forgot. But more importantly, this is important. Zone 3 on each side was most frequently involved. This is not known in the literature. Nobody talks about zone 3. This is ovarian fossa. We even divide this fossa as cliff, right underarm of the ovary, and the periurethral and hypogastric reflection. But zone 3 is very prominent. Nobody writes about that. We think that it is more, pathologists write that more common on ovary because they see that's what they see. They don't see what they're. And we think it's more in cul-de-sac or uterosacral ligament. Deep endo is more frequent than uterosacral ligament. So very important part is the fibrosis and inflammation portion of this. This is how it is. Zone 3 is, in this graphic, you see prominently these two sites are more common. And when you look at the distribution more, prevalence of fibrosis and inflammation with endopositive lesions are more on zone 3 and very prominently there. And between left and right, again, more prominently it is left. Sampson was right. The retrogradness of the period has a point. We see more on the right diaphragm and things like that. So I just want to share this by the record. We can discuss this later. And when we're really correlating this with the patient's symptoms also, and we're going to correlate more with the age groups and things like that. So it's a big job because we have a huge data there. Early detection and proper management and timely intervention is the best prevention. I wrote here, ending endometriosis starts at the beginning. Not for this patient. She is 62 years old, admitted to emergency room. She is on estrogen replacement treatment plus bioidentical creams, pills, vaginal suppository everywhere. She came through the emergency with a hemoperitoneum, acute abdomen. And when you look at the peritoneum on the left, on the right, you see this is a normal peritoneum. It looks, everyone. No, to me it didn't. So I look under blue dye, under water, and then retroperitoneal push off the blue dye. This is what I get. This is a very old picture. I'm sorry, I could have gotten better shot, but the bottom line is, if you remove that peritoneum, this is true of that patient, and you slice this with this technique, pinning technique, you see that endometriosis is over there, right? This is exactly from that patient. I appreciate my pathologist doing this for me, gland and stroma. What you don't see is, obviously, with triple trichrome staining, you see more inflammation vessels. This is regular pathology can do this. I'm not a scientist. I'm not a, but I operate at this level. Pathology is important for me. There's nerves, there's blood vessels, muscles, and nerves are trapped there. So it is important for me to present this because peritoneal endometriosis, these are the estrogen receptor situation, and more hyperplastic mesothelium. The reason I presented that is peritoneal endometriosis is not superficial endometriosis. It is more than that. There's more to see. There's more going on. There's stem cell action due to inflammation there. Peritoneum is more than a membrane. It's like our skin. It's the skin of internal organs. It covers from diaphragm all the way up. And the patient's symptoms correlate that. The patient comes with not just painful period, 90%, 80%, there's GI symptoms. Those GI symptoms are peritoneum-related GI symptoms. They're not uterine contractions or cramps. So Gray's Anatomy, this is true. They really labeled peritoneum as an organ. There are books about it, organ in health and disease, because other professionals see how important it is in other diseases. What we see is endobelly has a lot to do with peritoneal involvement in patient symptomatology. It's not parietal peritoneum, mesenteric peritoneum, it covers everything. So I'd like to put your attention to this. And also the circulation of the fluid, peritoneal fluid is people say, well, it is this because of the bowel movements. It's the heart. Pericardial beats every 60 seconds, beats every minute, pushes the peritoneum from the left. It's all physics. And the peritoneum is drained to the mediastinal cavity through the right side. That's why we see diaphragm endometriosis 99%, even more on the right side. So you have to think of peritoneum as, I look at peritoneum as a computer screen with pixels, and every lesion in my mind is microcircuited to the upper centers, and brain reads it as pain. Every lesion is a microcircuit. You cannot deny it, because even a small lesion, you think about a mosquito bite or a pimple, you can't even see, it's deep, but it bothers us so much. Nobody sees, only you feel it. Imagine a patient like this, multiple 80 lesions, but nothing is showing up in the x-rays and the test. Peritoneum is shiny, transparent, smooth, incredible organ. I'm in love with peritoneum. Well, this is not superficial endo. It's so thin. Diaphragm, central tendon is so thin, actually. And most of the pneumothorax happen in the just above the liver dome. These don't, on the muscle side, don't cause any hemoperitoneum. So this is true. I have done so many of these. I sent it to pathology. I begged them, and they did it. They looked under this debris. We see glands there. And these glands are live, like Sampson finally argued with Novak and everybody. And these glands most likely gets trapped into certain things I'm going to be mentioning now. This is angiogenesis. It's the sole part of peritoneal pathology. I think you may have different pictures, and I like to take these pictures. It gets me going. And you see how wonderful that angiogenesis is represented there, and look how disseminated it is through. These are going to be deep lesions later. This girl is 15 years old. And it's not only that, because of the pressure, we don't appreciate the physical property of these papillary things. They do float, and you can get them. I'll show it later. Look at this picture. I'm sure experienced surgeons will see some endo here, or may not. Do you see anything? You can make a comment. It's cervix is there, bowel, cul-de-sac, right side. Look what happens. We put the blue dye. There is endo right here, but look at the destruction of that beautiful peritoneum. It was multiple holes. That's inflammation. And when you give this to pathologists, they won't see the holes. Only I see the holes. And pathologists may write normal. And even in these areas, that holes, stroma positivity comes. That could be discussed later. So these potholes, I call them potholes because I think it's like the blood gets trapped in these holes and become the original seeding, like we plant our pots. Or they are pores, and in diaphragm, it becomes holes. Look at these wonderful lesions, and up there with blood there. Look at the thickening of the peritoneum here. I'm going to show these pictures fast. Again, it's the same thing. You don't see distinct pathology, but when you put the blue, you block the underlying red and yellow hues because it's absorbed by blueness, and it gives you. And I registered. I'm a Chelsea fan. Blue is the color. Okay. All right, we're gonna move. These pop out as small lesions like this, like a. And these bleeds later. Look how interesting. What you see is, you see here the blood, and then look underneath that. There's another small lesion there, and it goes. Look at the vascularization underneath. It's being fed. This site went to oxidative stress, that, most likely. There's a lot. You guys are talking about it, and the scientists know this. And experienced surgeons know this. I'm going to move fast. So these are like more of these lesions. And it has, I love this picture. It's like little grape pieces popping out with different colors. I can't see this if I don't do the blue. Look at these. Look at this little, again, this is a previously excised site, and this is a recurrence, actually, on a case that we did. But if you look here, on the side, the borders have a deeper and more fibrotic component there. And under blue dye, underwater, look how these projectile buds are moving. They're moving. But you can't appreciate it if you don't examine this underwater. This is interesting because this is again a repeat surgery on a patient. On the right hand, I have removed this area completely. All right? So then I excise this. This is a floating, as you see, these projectiles were floating like you see here, right? You see how they are flickering again? So I biopsied this with very fine 3 millimeter forceps, and this is how that floating thing looked like under microscope. You know what? There's no gland there. It's all stroma. This is it. It's all stroma, no gland. That's the piece over there. No gland. CD10 confirms. Guess what? When it sticks to the peritoneum, other part, in the same lesion, the glands are there. Look at this. Somebody has to explain this, okay? And we stain this is it, you know. Again, more, it's like a mushroom nuclear bomb. Look at this. I mean, I just want you to be with me this here. So in the end, this is peritoneal endo. It doesn't show anywhere. Look at this, how extensive the explanation is. And these are, again, and they bleed. Different patients, but I'm grabbing the moment. So it's all about inflammation and fibrosis. I think going after inflammation and fibrosis is part of excision surgery. This is an excised area. Look how fibrosis extend downward. It's like dendrites, right? And there is significant surface tension. When you remove it, maybe it's the pressure of, but there is surface tension. When you excise without any cautery, anything, central part of the lesion contracts and the periphery goes like that. And I kind of animated that in my simple mind. But look at this. You see this? Tenting very tight. You don't want it to your wife or any kids of you. God bless, you know. Anyways, thickening. Look how the peritoneum gets thickened, left versus right. And this is underneath how these holes look under peritoneum. I'm looking under the lesions. This used to be like this, beautiful, wonderful connective tissue. This connective tissue is the target of deeper endo. This connective tissue turns into it like egg white being cooked, and it's replaced by fibrosis, diffuse fibrosis. Fibrosis is different than adhesion. Fibrosis happens underneath the peritoneum. I call it like that. I differentiate it. Anyways, but the holes are active. Look at this. You give pressure, they're like, this is important. Maybe the patient feels, according to some, Bruce Leslie explained this very well. He says these holes, he did it on different setting, but he says these holes really get the necrotizing blood and everything. It stimulates the nerves more. That's the cause of. But probably these pores, holes, potholes, whatever you want to call it, is the same thing that causes diaphragmatic holes. Most likely, I believe that. It's the same thing, but central tendon is so thin actually, it doesn't cause anything there, but it causes, when you do blue, you can appreciate this. So it's all inflammation. This is cul-de-sac. It's again fibrosis, as you see. You have to, I mean, it's horizontal fiber. It's not dip, but my apologies. I'm going to go fast. This is important. Peritoneal fibrosis involved throughout life cycle, and it starts with cardinal symptoms for menarche, and then later, this is a timeline of symptoms. Then later, when they are sexually active, bowel symptoms really get more serious. Whatever discomfort becomes diarrhea, constipation, dyschezia, endobelly, obviously anxiety and then chronic component of the pain, constant out of menses, pain continues. Then infertility, obviously patient goes many misdiagnoses, mistreatments in the middle, and late diagnosis. What is important, we don't know. What happens in Telarche? When that period of 2 years, when the estrogen pump starts from the ovary, the uterine size changes, fundus grows at the expense of cervix maybe, endometrium gets formalized. We don't know that, but many patients, I talk to pediatric gynecologists, they do complain of abdominal discomfort way before period really starts. And we don't know other things, what happens with birth, neonatal vaginal bleeding. We know that happens. And also during gestation, the endocrine disruptors are there, and obviously familial predisposures. I mean, I was fascinated when I started in this foundation with my twin sister. They were 41, but they both came with advanced endometriosis. After that, they got pregnant. They were lawyers. They become my major speakers and everything. But the other girls are 19, 20. But these girls on the right could have been diagnosed much earlier. And it is, obviously, this is the timeline of other endometrioma pops out when they're 25, 30 in general. I mean, in my observation, this is my estimated things. And bowel disease later comes, more pronounced. Patients on the average bowel disease are older. But more importantly, chest cases. We have close to 70 chest cases with, on the average, their ages 35, 34. Why? Because endo is progressive. In some patients they heal, in some patients it takes off like a Mack truck, big horsepower. That says endo is progressive. Many of these patients, when you look chest cases, 75% of the time, there's very advanced endometriosis inside. So unexplored space in endo is, I think we have to really look at these newborn period is hard to make, but sometimes I think we all know there's something called decidual cast. I personally think there may be some involvement, something like that. We don't know about uterine motor electrophysiology, have hyperperitalosis, and other thing, rectosigmoid redundant colon. I've been seeing this like curves, like caves in the pelvis. Also, there are folds when you have redundant colon. Endo gets squeezed there and sets up this infiltrative thing. We have quite a bit. We have at least 5, 6 cases. I learned this later, and the patients, nobody wants to operate on this, but some patients we did operate. And this is a pilot from Alaska. She's a good speaker. So the bottom line is, I'm almost done. The bottom line is excision surgery. You have to excise completely. When you commit for excision, you have to be prepared to fix your rectum at times. We don't know how deep it is. And the sonograms are not going to show that 3-4 millimeter depthness where you get into trouble. So you have to be able to fix your rectum, ureter, and this is a little animation of which I show patients, but it's important. With no energy, I prefer you cut this and it goes. So this is how it happens. I do this typically. I try to excise. The idea is not use any energy and cut it without energy, so your borders are not cooked and you don't have retained. I just do it to see how I left that tissue behind. So I'll go and fix that too. My time is almost over, but I call this focally targeted excision instead of peritoneal stripping, which has no respect to the patient's pathology. Indiscriminate stripping is not normal. We also do some uterine suspension, temporary, sometimes in these cases. In some cases with very low AMH, I have pregnancies like this too. bypass, bring omentum into the ovary. So my last slide almost. What we observe is not nature itself, but nature exposed to our method of questioning. Be open-minded. This is Heisenberg. She's a Nobel Prize winner physicist. But for endometriosis, we can say what we observe in endo is not endo, but the endo exposed to our method of questioning. Thank you. Always find time for things that make you feel happy. This is my gems in my life, Lara and Perry. Thank you very much.